granted by SICOT, Society of International Congress in Orthopedics and Traumatology from Berlin, Germany, in arthroscopy and trauma. He also completed a fellowship in sports surgery and arthroscopy from Cardiff, UK. He has presented his papers in many international orthopedic conferences and also published his research in many international journals. Now he is working as Chief Orthopedic Surgeon in PMH Kannur. Now I invite Dr. Jyothiprasanth to deliver the speech.
There's a point one.
So a very good evening, one and all. Very good evening. So first of all, I would like to thank the stakeholders for IMA to invite me to deliver this talk over here. So the topic, I'm quite familiar to you all, and I've been here for a few times, maybe in the past few years. So the talk is, are X-rays deceptive in orthopedics? So that's basically X-rays are the preliminary investigations which we all order. But are X-rays enough, or are they deceptive in today's orthopedics? In 2023, are X-rays enough? So that's the topic. So this is a guy who invented X-ray. Actually, it was a serendipity. His wife came to call him for lunch, and in between, her hand was stuck in the cathode ray in between. And this is the first X-ray which was taken. That is the X-ray you can see on the right side. So, and he got a Nobel Prize for it, for the X-ray. So this was a really great landmark in the history of modern medicine, because X-rays are used in all modalities nowadays. Here you can see in operating theater, you can use for as a C-arm, you can use it. You can take this is a C-arm machine, which we use it in OT. And CT is another form of X-ray in which we use it, you know. So CT has become advanced using the X-rays, and the cath lab uses X-rays. The O-arm is there, which is an advanced form of C-arm, which gives three-dimensional imaging with X-rays in operation theater, especially in spine. So the basic thing is that in 2023, but even after this much of development of X-rays, are X-rays enough, or do we really miss out anything in X-ray? That is the question. So sometimes a patient comes, the X-ray is normal. You just tell them that don't worry, your X-ray is normal, okay. But ultimately, after some time, they go and find something else, and which turns out to be more bad than a fracture. So that is a problem. So in this X-ray, can anyone just read the X-ray or tell anything is wrong in this X-ray, please? I wanted an interactive one. That is why I put this X-ray. I put an arrow there just for. Can anyone tell, sir, what do you think about X-ray? Yeah, that's actually, it's not an osteophyte. It's a SICOT fracture. It's a telltale evidence of an anterior cruciate ligament injury. So it's a ligament avulsion. Okay. So in the lateral aspect of the knee, there is an avulsion fracture, but the ligament is gone in the central aspect of the knee. There is an ACL injury actually in this knee. So I'm just telling that X-ray shows that small fragment there, but the ligament is not gone at that point. Ligament is gone in the inside of the knee, the ACL. So what can we do for that? Another thing is a patellar dislocation. So we should take a proper views. That is a sunrise view. That is, you take the knee in flexion and to see the patellar dislocation. If you simply take an APN lateral view in X-ray for a patellar dislocation, you will miss it. So this is another one. So what do you think about this X-ray? Any orthopedician in it? No one. So obviously this is a tough question. But anyone can attempt. What do you find in this X-ray? Yeah, exactly. So it's a posterior dislocation. Most commonly, it's an anterior dislocation which occurs in most of the people. But this is a posterior dislocation. So here you can see the normal contour is gone and you can see a light bulb sign. That is just like a light bulb, it is kept. So this can be easily missed. So in the X-ray itself, we can see it, but we should, what do you say? But I see only what the mind knows. So we can miss it out. So in this X-ray, do you see anything? Anyone can tell me, what do you think about this X-ray? Is it dislocated? Anything else? So here you can say that this is actually an X-ray which shows a mild superior migration of the humerus. That is the humeral head. The humeral head here. I'll point here. Okay. See, this is a space between the humeral head and the acromion. Normally, the rotator cuff muscle comes here and it is occupied here. So what happens is that when the rotator cuff is torn, you don't see anything in X-ray, but if you carefully look, you can know that there is a superior migration of humerus. So this will not be seen in X-ray. It will be seen only in MRI. And what happens later, after some time, it becomes obvious to anyone because the humerus migrates upwards and rubs in the acromion and creates an arthritis there. So in initial X-ray, we might pick it up, but still it can be missed. So here the arthritis, when it has developed, then there is no point in diagnosing it because cuff repair will not help. Maybe a joint arthroplasty, like a total knee replacement, a total shoulder replacement should be done for this patient. See that. There's a total arthritis over here. So what happens is that after initial fall or trauma, an X-ray, you miss many things. And ideally, you should take an MRI to assess that. Then only we can prevent this from happening. That is, this arthritis is there. See, here in this MRI, you can see that the cuff is there going like this, and you can very well see the cuff. So even you miss it in X-ray, you can see the cuff. See that. This is a difference in the cuff. See that. This is a normal cuff. This is a muscle. It is coming and attaching to the tendon in the bone. Here you can see the torn cuff. There is nothing over here. The muscle is being cut here, and the remaining part, the remaining rotator cuff is being here. So in MRI, it is just clear, just like daylight, because the cuff tear is seen in MRI properly. Here also the same thing. And so what can be done for these cases? So all these cases in which we miss out something is picked up in an MRI. That is, it could be ligament injuries, it could be muscle injuries. Mostly in the knee and shoulder, the ligaments and muscle injuries are more common than fractures. So fractures are occasional things. Ligament and muscle injury are more, but you miss it out because in X-rays, you won't see it. And moreover, sometimes a patient comes to you with maybe the MLC or RTA case. You tell that it's okay, there is no fracture or dislocation. Ultimately, the patient lands up to have a rotator cuff tear or a ligament injury, which might cost them more than fixing a fracture, maybe, because it will be more costlier surgery. So ultimately, the initial doctor who saw them and told that there is no problem to him will be under what to say. The patient will consider them as a devil or something. So people nowadays are looking reasons to picturize doctors as devils. So that is why I'm telling. So in X-rays, we can miss many things. So obviously, we should at least suggest an MRI because rotator cuff or ligaments or meniscus, more things can be missed out. So you can just suggest that in X-rays, you can see only bones. So if the pain is not going, you might need to take an MRI scan to evaluate whether other things are problematic in your joint. So that is the main take-home message in this slide or in this entire talk. So what can be done for this is mainly we do arthroscopic surgery. That is keyhole surgeries for these kind of injuries. That is the open, you can see the difference between the two surgeries. Here in the open one, you are put a big incision over there. In arthroscopic, there is actually not much scar seen. This in the shoulder, you can see a big scar in the deltopectoral groove. In arthroscopic, there are only small scars. So the requirements are not that huge, now most hospitals are ready to purchase arthroscope because they know that they will need it at some point of time. So all began maybe at 1806 when cystoscope was used to visualize the bladder. So in 1806, it all began by origin of minimally invasive surgery, the Bozzini. And nowadays, most of the sports person are being treated in arthroscopic this thing only. So in 1879, a light bulb was invented, and this light source was very important because earlier people used to see through the small scope, and now the fiber optic cables have come. The TV monitors have advanced. So it becomes a very more advanced surgery when considered in the old age. So what are the conditions in the knee that are treated arthroscopically? It's basically, as I told, ligaments and meniscal tears, early stage of osteoarthritis. Early stage need not go for a total knee replacement. You can just do a partial synovectomy or damaged meniscal repair, and you can get relieved of the pain. You can take synovial biopsy. You can do septic arthritis lavage and arthroscopy assisted fracture fixation. You can see the ligaments over there. So these are the ligaments, anterior posterior cruciate ligament and the meniscus. So here we are doing a replacement of the ligament. The anterior cruciate ligament is being replaced for a sports person. This is a meniscal tear. You can see the meniscus is being repaired over here, the meniscal tear. The stages of osteoarthritis, in stage 1 and 2, arthroscopy might do well, but stage 3 and 4 maybe might need a joint replacement. The cartilage repair surgeries, which can be done arthroscopically. Earlier, the patient did not have much to offer in cartilage injury. Now we can do microfracture. We can harvest cartilage from non-articular areas and plug it in. That is called OATS. And as I told earlier, arthroscopic lavage can be done. And fixation of fracture, loose body removal. And mainly in shoulder, as I earlier told, the muscle tears can be addressed arthroscopically. And subacromial impingement, that is impingement syndrome, can be addressed arthroscopically. Calcific tendinitis, that is another issue. And the AC joint disruption, that is the acromioclavicular joint, usually sometimes dislocates and it can be addressed arthroscopically. Rotator cuff tear. These are the suture anchors which we use arthroscopically to put in the bone and catch hold of the rotator cuff muscle tears. So ultimately, if it doesn't work, you can replace the shoulder. So this is a reverse shoulder replacement. And telling that we are conducting a shoulder arthroplasty conference this Sunday. You will be having the brochures right now in your hand. So in Kannur, we are doing it. In the Kannur Orthopedic Society, we are conducting a conference on shoulder arthroplasty. So if anyone is free, please visit. Please be free to visit there at Binale International on Sunday. It's in April 30th, this Sunday. So we can also repair a Bankart repair, that is shoulder joint dislocations, chronic dislocation. We can do it in keyhole surgeries. And mainly they have arthroscopy has got distinct advantages. That is, hospital stay is less, the scar is less, and obviously a high degree of suspicion and prompt referral is necessary because sometimes it might be missed. So thank you for your patient listening. Thank you so much. Any questions from the audience?
The X-ray was the X-ray. We also agree that X-ray is important.
Yeah, definitely. I told you that
You can talk both ways.
yeah.
We know that for the using center patient for a moment, then maybe diagnosis may be taken by X-ray. And another patient comes to you, always suggest you take the BP. So this was routine. So very easy and cheap investigation. That can give you 50% of case. That's the thing. So like that explain because nowadays experts to advertise to report the X-ray, which is coming there. Because you can see a lot of things in X-ray. Just see the bad line, see the indirect lines. So this will take you the diagnosis. Only thing that we are losing that because nowadays radios are not getting it. So we are not more concentrated on the X-ray. So we are totally more on secondary and market. So if you get the X-ray, because if you go to other parts of India, right? With the X-ray is not a good very growth. So they will then the radios also very important. And they are good in the diagnosis. The old guys are good in diagnosis. Indirect, because indirect side.